So yeah, thank you for having me. My name is Luke Griffiths, and I'm one of the chief residents over at the Smith Institute for Urology. So still a chief resident, nothing to disclose yet. So today, when I was asked to present, I was thinking of some of the different areas of interest, and I settled on a topic that I think continues to be a challenge in urology, which is the sepsis rates after PCNL. So today I will talk about our history, some risk factors, and finally some of the novel things we're doing to help improve these complications in the field. So a little bit about myself. I'm one of the chief residents. I'm over at the Smith Institute. This is a picture of one of our two main campuses that we operate out of. This is the Long Island Jewish Medical Center. It's primarily where we have our cancer cases. And our other hospital is North Shore, so that's where we primarily hold our endourology cases. Of course, there's many other satellite hospitals that we work at or rotate through. Those are our two main campuses. Our home outpatient base is actually located across the street from Long Island Jewish Hospital, and that's in the old UN building. So they took that building and then renovated it and set it up, and now it's mostly medical offices. And it's also where we have our ambulatory center for surgery as well. So for many of us, this is a story we have heard before, and so I won't spend too much time on it. But going back to the origin, in 1941, Ruppel and Brown, in what would be the first to describe nephroscopy, it was in a 44-year-old female who was found to have only one functioning left kidney with a 1.6 centimeter stone, an exceptionally large right stone, which filled up the entire kidney. She underwent a right nephrectomy, presumably for an XGP, and subsequently developed anuria and required nephrostomy to be placed through her incision when they could not advance past the stone endoscopically on the other side. So the plan was to cut down and make a pilotomy to remove the stone. But then they decided to utilize the existing tract by threading a rigid cystoscope over the catheter and passing it to the kidney, where they were successfully able to remove the stone. The first percutaneous nephrostomy tube was placed by Dr. Goodwin in 1955. And he was trying to perform a renal arteriogram and inadvertently placed a needle into a hydronephrotic kidney, where when injecting contrast, also performed the first antegrade nephrostogram and left the tube to drain the kidney. So he also placed the first modern nephrostomy tube as well. The first to describe the technique for extracting renal stones through a percutaneous nephrostomy under radiologic control was from Fernstrom and Johansson in 1976. And then in 1978, Dr. Arthur Smith described the antegrade placement of a ureteral stent over an opacifying collecting system, which was done with an intravenous pilogram at the time. They punctured with an AT gauge cannula needle, and they put a guiding wire down the ureter, and sometimes they would use a 5 French or 7 French to help guide this wire down, similar to how we do today, and advance the stent over the wire, and then grab the distal end with the cystoscope. He's also given credit for coining the term endourology, and is also one of the founders of the Endourology Society. He's a namesake of our department, of course, none other than the Arthur Smith Institute. He recently retired, but he was always full of wild ideas, which was not limited to the operating room. He had many tools, one of the tools which he used today was helped developed by him and Dr. Clayman when they worked with Kurt Amplatz, an interventional radiologist and an inventor. And I was lucky enough to work with him on a few projects. He would always be on the lookout for anyone who could help him put together anything for one of his talks, any one of his PowerPoints. And then one time he came to me and he asked me if I could help him to put together a Photoshop image of Dr. Ralph Clayman. So it was a debate where and he came to me and he said, "Can you put something together for Dr. Clayman?" And I want him to be put in some pretty ridiculous situations. One was involving a pig, another was upside down in a harness to figure out how to perform ureteroscopy in a prone patient. So always a good laugh. And I'm only highlighting some of the innovations, but the field of endourology has continued to expand rapidly. And specifically with PCNL, we've been finding more ways to access and more ways to destroy and remove stones. While PCNL offers the highest stone-free rate in large stones for a minimally invasive approach, it is not without its complications. And we could do an entire talk on the complications of PCNL. But today I want to focus primarily on sepsis. So the rates of infection and sepsis after PCNL vary largely within literature. And this is partly because definitions also vary in the papers that were reported. Some papers report just the fever rates, the sepsis rates, or the systemic inflammatory response rates, the SIRS rates. And they also vary on how they define these different subjects or these different areas because of there's different definitions within the literature themselves. So, for example, some studies may take just one or two of the components of SIRS, or some studies will utilize all the components as their definition for sepsis or for managing these different areas. So, it is also important to understand that SIRS and sepsis are separate entities, as sepsis by definition includes an infectious etiology, whereas with SIRS, it's primarily referring to the dysregulation and the dysregulation of inflammatory markers by the body's defense mechanisms. This point was highlighted well in a recent talk given by Dr. Benjamin Canales, where he discussed SIRS versus infection. And where this systemic inflammatory response syndrome has many similarities with infection. Sepsis can encompass SIRS, but it also may involve the immune dysregulation, increased microvascular permeability, leukocyte, leukocyte accumulation, and may lead to this dysregulated vasodilation, which we see in the setting of septic shock. And of course, that's a form of distributive shock. But how do we lower our rates of sepsis and rates of SIRS? Post-PCNL fever is seen frequently despite preoperative sterile urine cultures and prophylactic use of antibiotics. And it's not always infectious in origin. One of the earlier studies performed by Gonen et al., and this was published in a prospective study of 61 patients who had undergone PCNL. This is in 2008. They were prospectively analyzed with respect to postoperative fevers compared to those who had no fevers. And they found increased stone size and increased operative time were associated with higher rates of postoperative fevers. These findings have been corroborated by more recent studies. But as the definitions of fevers, sepsis, and SIRS were utilized as primary outcomes, there's different heterogeneity in these cases because of their different definitions. However, we can break down our risks into preoperative, intraoperative, and postoperative factors, which are also implicated by diabetes, degree of hydronephrosis, number of tracks, duration of the operation. Some studies will quote blood loss as a risk. So these studies are important, however, as we have an idea of where our risk factors come from. And when we understand where the risk factors are coming from, it allows us to begin to develop a targeted approach to implement change. If we look at preoperative risk factors, patient selection will make a huge impact on the potential outcomes of your cases. At large referral centers such as Northwell, and I'm sure such as Yale, you get a large number of these more complicated cases. Now, at our institution, there's a few private urologists or non-formally endourology trained urologists who they'll do PCNLs. They do an excellent job. Many of these patients can be tubeless, same-day discharges, and they do extremely well. But when we start looking at their patient selection, they're not getting the C4 paraplegic gunshot wounds, the quadriplegic with a contracted recurrent stone former, or the patient who lives with the internal and external tubes, recurrent UTIs that can't come off their anticoagulation. The running joke when any of those patients are referred to these urologists is that they say, send them to the professors. And they mean Dr. Honig and Dr. Okiki. who are willing to do these multiple staged procedures with multiple sticks and perks and accesses. So what can we do to optimize our patients in the preoperative period? And especially our higher risk patients. Intraoperative risk factors reported are unsurprising, as larger stone burdens portend to longer operative times, and staghorns or struvite stones are harbors of bacteria. Targeting intraoperative risks for improvement also presents an area that we can improve upon. And how can we perform this surgery more efficiently? How can we avoid higher pressures, which can potentially lead to inflammation and bacteremia? Post-operative, our procedure is completed, but do we leave nephrostomy tubes? Do we continue antibiotics? One common denominator amongst all areas of concern is that antibiotics are our number one defense against infection and are utilized in all stages of patient treatment. So what does the AUA have to say about this? What are our guidelines? Well, there actually are no official guidelines for PCNL, but there is a best practice statement. And they recommend in low-risk patients only 24 hours of antimicrobial coverage in the perioperative period for these low-risk patients. But what do practitioners actually do? So this is an interesting study. It was published by Carlos et al. And it was investigating the antibiotic variability in a variety of pre-ureteroscopic and pre-PCNL cases. So what they did was they issued a survey to members of the Urology Society. They got a 16% response rate. It was actually not terrible. If anyone's ever done these studies where you're sending out surveys. They had 326 responders. And the majority of these responders held academic positions, had over 10 years experience, and had done plenty of cases. So here's a couple sample scenarios that were presented. And their answer choices were preferentially on antibiotic usage. So just to kind of briefly go over it. So we have one of their questions they said is ureteroscopy is planned for a 45-year-old healthy female with a 12-millimeter uncomplicated stone located in the renal pelvis. Her preoperative urinalysis shows no pyuria. Her urine culture is negative. So what'd you do? Would you give no antibiotics, single dose, 1 to 3, 4 to 7, or greater than 7 days? And another example is a patient had a PCNL. It's planned for a 42-year-old healthy female. She has a 2-centimeter uncomplicated non-staghorn stone. She has an asymptomatic positive urine culture sensitive to oral antibiotics. So in this scenario, would you treat it? Would you give none, et cetera, et cetera? So those are the questions that they gave out. I believe it was 13 questions in total of these different scenarios. And so they found large variation in the usage between practitioners based off of the scenario. This is with negative cultures, as well as variation within and between countries with regards to both positive and negative urine cultures. Within our own departments, I know within our department, we see variation between whatever attending is doing the procedure. I've seen it at different programs I've visited. I know when I was down, I had visited George Washington University and was talking with somebody who had presented from Hopkins and was giving a presentation on PCNL. And when I talked to her, she was saying that there was 2 weeks of antibiotics she gives before every case and 2 weeks after. So it varies a lot between different practitioners. I'm sure even at Yale, between practitioners, you might have lots of different variability. But what does our data actually show, and where are our recommendations based off of? So there are 2 excellent studies worth highlighting, which are part of the EDGE consortium, which they were looking at the low risk as well as high risk cohorts. So this first one is from Chu et al. They evaluated perioperative antibiotics in patients with neither a history of positive urine culture nor any prior history of ureteral stents or nephrostomy tubes. So no positive cultures, no external tubes in these patients. And that's what put them into what they were defining as the low risk patient. They had 86 patients who were randomized to a control or to an intervention arm of receiving nitrofurantoin for 7 days prior to PCNL, or with just receiving less than 24 hours of postoperative antibiotics or peri. So within these two groups, the treatment and the control group, they had reported rates of sepsis at 12 and 14%, respectively. The only significant difference was that nephrostomy tube placement in this setting they were finding was protective factor against sepsis. But in this multi-institutional consortium, they also did a similar study in high-risk patients. So they found between this 7 days of antibiotics to no antibiotics, there was no difference between their sepsis rates. When looking at their high-risk cohort, however, so with Sir et al., they included patients with a prior history of recent positive urine culture, indwelling stent, or nephrostomy tube undergoing PCNL. So this is basically the exact same protocol, just with they're taking their exclusion criteria now. This is their inclusion criteria for this new study. For these patients, they were deemed as moderate to high risk, and they had 123 patients. And these patients were randomized once again. They were considered, they had, of course, the positive culture, the tubes, and unsurprisingly, the sepsis rates were higher in these higher risk groups. What they found here, however, was that patients who had received only 2 days of antibiotics, that 1 in 4 of them became septic. And this is compared to the 15% in those who had received 7 days of pre-treatment. And then in a finding which was not statistically significant, but is interesting, is that in a post hoc analysis, it was that those who had Staghorn stones had a larger difference between their sepsis rates. So the 2-day rates versus the 7-day treatment course. So it's 27% versus 9.1%. So while this supports the AUA recommendation, there are very few studies looking at post-operative sepsis rates. And post-operative treatment protocol in both studies were only up to 24 hours of antibiotic treatment until further treatment, unless further treatment was needed because of their sepsis. So this was an area which we wished to evaluate at our institution. We put together a prospective randomized control trial, and we wanted to evaluate patients in the low-risk cohort. So we looked at patients who had a negative urine culture, there was no external tubes, and no prior procedure. We randomized 100 patients who were undergoing PCNL, and that went to either one group who received 24 hours of antibiotics as recommended by the best practice statement, or we continued the antibiotics until their external tubes were removed, because we wanted to give more of a real world scenario where a lot of people were doing similar practice patterns. Our procedures were performed in, I'm guessing, a similar way to when you trained here, Dr. Modvidinia. So we had patients placed in the prone position for this study. All of them were dilated to 30 French, and external tubes were left at surgeon preference. We found that rates of infectious complications were similar between both groups, with low rates of sepsis and low rates of SIRS. So we had a 12.2% rate of SIRS in the 24-hour group. And this was compared to 14 in the continued antibiotics group. So there was no difference between those groups. And our conclusion was that it was in agreement with the best practice statement of the 24 hours of antibiotic coverage in the low-risk cohort. But how do we guide our post-operative care? In truth, it is primarily guided by our cultures. We now routinely obtain stone cultures in all of our cases. And as we know, that we found through studies that they have one of the highest odds ratios for risk of infection when we have positive stone cultures. And we also routinely found that we also routinely look at, found that negative urine renal pelvis cultures but positive stone cultures will commonly happen. So, we'll take studies of the renal pelvis culture, the stone culture, and many times the pelvis is negative and the stone is positive. And so in these patients, it also helps us direct our treatment. Not really sure what you guys do over here. I don't know, Dr. Singh or Dr. Motabedinia, if you guys are on with, do you guys collect stone cultures?
On occasion, if it's a higher risk patient or if they may have had a negative culture, but it looks like a very soft infectious stone. I did it initially when I got here more routinely, but it wasn't really changing my practice. But now I'll do it if I have a high suspicion of perioperative sepsis.
Yeah, so and from what I've seen, it's a similar pattern with many other institutions. It's not routinely gathered. One of the challenges, of course, is how do you send this culture, because some places won't actually send a stone culture unless it's broken down. So what we try to do in our institution is when we collect the stone culture, we try to collect it sterilely. So no, we try, if it was ever handled or outside the body or placed on a napkin or on a gauze or lap, whatever, what have you, we don't send that one. So we'll try to take it directly out, put it in a collection tube, and then break that down with some saline, and then we'll send that for a sample. Our pattern is a little bit different now as well because of some studies that we've done with antimicrobial irrigation. So looking at some of our innovation, future directions, there's some area for improvements outside of antibiotics without systemic antibiotics for how we can treat these patients. So this is primarily how we perform our PCNLs now within our endourology team. We tend to incorporate some form of antimicrobial irrigation, but one thing that we have done more recently is we're also including betadine wash inside of the renal pelvis to help sterilize the field. So this is a study was performed by Dr. Rai, Dr. Okiki. This is not a randomized trial, but it was prospectively collected, and they included all patients, so there's no strict selection criteria. So it's a bit of a heterogeneous mixture of different patient populations. But they took 56 patients who were undergoing PCNL, and we did betadine installation. They found that there was lower risks of lower rates of sepsis, fever, and SIRS compared to to other published studies in the general population. So there was no comparative arm in the study. But this is pretty much how we do most of our procedures now. So we place the patient in the prone position. We'll do a cystoscopy with a ureteral catheter insertion. And that first catheter that goes up, we'll see if we can get any sort of drip out of that. And so we'll use that as our first renal pelvis collection for culture. Once we obtain that culture, we'll use this open-ended catheter to instill about 10 cc's of betadine into the collecting system, while we'll get ready to get our access. So that allows things to be coated in this betadine to hopefully sterilize some of the field. We'll then mix some betadine with some contrast and use that for when we're getting our fluoroscopic access. Of course, with ultrasounds now can sometimes be slightly more variable. And then we'll get our access. And in this study, they were doing that to obtain the access. You'd see the betadine coming out from the needle. The PCNL was performed with, in this study, gentamicin in the irrigation bag. And here's an image. So you can see on the left-hand side of the screen is the open-ended going there, and we're instilling the betadine into the collecting system. And the middle image there is we're getting the betadine drip coming out. On the right, you can see with our access, which is primarily done, different practitioners, different endourologists will use different accesses. Dr. Honig will continue to use 30 French access on almost all of his patients, while Dr. Okiki and Dr. Rai will generally go with 24 French for their access, where they'll remove the external sheath on the nephroscope and just use the internal sheath as their access to get in. And then Dr. Okiki is also in certain patients doing the mini PCNL using the Clearpetra, which I'll kind of go over in a little bit. So our second culture is collected from the tract through the percutaneous access again. So we're going to get that drip coming down from the needle there. And the final culture which we obtain is from the stone culture. So we're trying to get cultures from all of those things. It started out as just study criteria to see if there's any change between pre and post wash for the betadine, and has just sort of become our practice pattern now, where they are obtaining all these three cultures. So another area of potential improvement within our procedures is pressure control. So this is a very interesting abstract. It was presented at the AUA. It was sponsored by Boston Scientific, and I'm sure this is when they're trying to launch their new LithoVue Elite system. But in this study, they had pigs which were irrigated at different pressures over an hour. One pressure was at 35 millimeters of mercury, and the other was at 75 millimeters of mercury. And they found that when sampling the pig's blood, not only were inflammatory biomarkers higher in all of the E. coli irrigation at higher pressures, but they also found that all the pigs treated with high pressure E. coli irrigation had bacteremia. And this was compared to that none of the pigs had bacteremia in the low pressure area. Another study looking at pressure flow fluid dynamics in PCNL, and more specifically in mini PCNL, was using the Clearpetra. I don't know. Do you guys have this device over? Have you utilized this over with you guys at Yale?
We do not have it. I do minis, but I don't use the Clearpetra.
Yeah. So it's actually it's a simple design, but it's pretty ingenious. So when you put it in there, you have this area that you can put your thumb over to obtain a suction, a vacuum. So you can continue high pressure irrigation through this device, but because of the vacuum, it keeps a lower overall pressure within the collecting system. It's kind of nice because you're able to break down the stones, and if you can get against a back wall in a renal in a calyx, or a back wall within the pelvis, you can create a pretty good vacuum that you're able to break down stones, and you don't have to go in and out with a basket. It just will kind of vacuum them out. And when it creates the vacuum, what you do is you'll pull back the nephroscope, and or the when we're using, it's the smaller nephroscope, you pull that back and it'll allow all the stones to sort of follow you back. And once they hit that tract where the pressure control valve vent is, they'll just get sucked out a side passageway. You can see there on the right side, and pulled into that, and you go right back in. So it's a pretty quick method of going back in and out. So there was a study that performs that looked at the Clearpetra, and so they did 122 PCNLs utilizing this system. And of course, one of the issues we have is that when you're using a smaller tract, you have a higher increase of pressure into that field. And there's less outflow that you're going to be working when you're working through this channel. So they had high success achieved with stone removal. And what they did was they put a pressure transducer through an open-ending catheter to record the different pressures at different steps of the case. Their highest pressures were noted during the nephroscopy, the final nephroscopy period, and through the closed irrigation when the pylography was performed. So here's some of their different areas. So it's interesting. You can see where they have the final nephroscopy was with closed aspiration. That was their maximal intrarenal pressure at 51 centimeters of H2O. And their percutaneous pylography through an access sheath had a higher pressure. So different times of the case, you had different pressures. Their mean intrarenal pressure was able to be kept pretty low at 13 during their procedure because of using this device. So another tool on the market is the LithoVue Elite from Boston Scientific. I'm not sure if they've given you guys a talk yet. I'm sure they will if they haven't. But this is their new disposable ureteroscope, and it boasts real-time intrarenal pressure monitoring and enhanced vision control. It also has, I believe, some device that allows you to do one-handed basketing while holding the device. But of course, it's not PCNL, but it's an interesting example of where our industry is moving, where we're getting newer technologies now to be able to monitor these things. And so that, of course, will open up a whole nother field and avenue for us to begin researching and analyzing. And lastly, I'd like to, this is again not PCNL, but it's just another area of interest within our field with clearing larger stones. So there's this device which we were demoing over at our institution, the CVAC. I first was told that stood for continuous vacuum assisted catheter. And then when I was writing a study up on it, the company reached out to me and said, no, it doesn't stand for that. It's CVAC just stands for CVAC. And that's how you're supposed to present. It's like, okay. In any case, so what this is if you're doing your ureteroscopy and you're getting into the collecting system with larger stones, you're breaking it down and you're popcorning and you get down to a smaller stone amount that we should say, okay, this will all pass. Well, and there are patients who are higher risk or have higher chance for struvite stones, or they've had multiple UTIs or infected systems. It's best to try to get as much of a stone-free rate as we can. So, of course, we can argue in these patients, well, if there's a large stone burden and they're higher risk for this to get a better stone-free rate, you could do a PCNL. Unfortunately, that's not always something that we can do in some of our older, more frail patients who can't come off of anticoagulation. So I think this hits an area of possible interest for this device. So the way it works is it goes through a 12-14 access sheath. It allows us to put a vacuum up there to suction out the already broken down stones. They recommend stones be less than 3 millimeters in size. So again, it's smaller. It's about 2 millimeters, usually what we say is going to pass on their own, but potentially can give us a higher stone-free rate. It's still early and it's still in its early phases. One of my big gripes with it is that you can't use vision with it. It's all done under fluoro, so you're sort of blindly angling the direction that you're going to be suctioning out. We had some short-term data with it. We presented at the AUA last year where we were looking at patients with stone burdens. They had over a centimeter stone, and we were able to break it down. So we didn't have much of a comparative arm, it was more just feasibility, but we did find that there was an overall pretty high stone-free rate in these patients when looking at postoperative imaging within a month. So it is an area of interest selectively. One of the major issues with it is the cost, of course. If you're thinking about a ureteroscopy, it's not generally an overly expensive procedure, but it becomes once if you're going to tag on an extra $12,000. So, of course, it's used in very specific situations. So, in conclusion, complex stone surgery has come a pretty long way, from open pyelothotomies to smaller and smaller accesses with newer technologies that have been developed with some of our greatest minds to come through our field. And we continue to innovate and work with industry. And though this is a reason many of us actually got into this area and interest in urology because of this new innovation that we have. Post-PCNL sepsis is a complication that continues to cause problems despite many of our efforts. And if we properly risk stratify patients, it does help with our planning and expectations when talking to our patients. But we need to target these other areas of higher risk with research to try to decrease these overall complications. And finally, antibiotics are our mainstay and primary defense against infection. But with growing resistances, we really need to find novel ways to approach the problem and continue to innovate to achieve the best possible outcomes for our patients. So once again, thank you for having me. And thank you for allowing me to give you guys talk today.